Yes, Julie.
Okay, lovely. Thank you so much, Rahul. Welcome back, everyone. We've had a bit of a hiatus, and I do apologize for cutting you off a few minutes ago. I was trying to work out technology, so apologies. But anyway, we are back again after all the PAS and presents and Easter breaks, and hopefully we'll kickstart a brand new session of online learning. So today we have a combo act. First of all, led by Professor Kusuda, who you know very well, who is chair of the Japan Neonatal Research Network and has been incredibly supportive and helpful for this Zoom series over the pandemic. He will talk to us about international outcomes and comparisons for the care of the very tiny infant, and has a couple of cool videos to show us as well. But for something very different from what we have been learning about in the last 2 years is the nursing care of the very tiny baby. And for this, we're very privileged to have speaking to us, Professor Konishi, who is a neonatal nurse and now currently professor of nursing at the Tokyo Medical University in Japan. And she has a long list of accomplishments, but she will show that to you when she gives the talk. So without much further ado, we'll pass it on to Dr. Konishi first. Thank you very much.
Hello everyone, my name is Miki Konishi. I'm with Tokyo Medical University School of Nursing. Thank you for the opportunity to give a presentation today. I'm very happy to be able to talk you, and I'm very surprised many people joined today. I'd like to thank you, Dr. Julie and Rahul and Dr. Kusuda. Today, I'd like to talk about neonatal care for a very tiny baby in Japan. Firstly, the nursing system in Japan. Secondly, information on direct care for a baby. Finally, family care in NICU. Before my presentation, I introduce myself. I had worked as a NICU nurse for 8 years, and 2 years medical ward, 1 year pediatric ICU and ER, 5 years in NICU. I finished a master course in 2008. I majored in family nursing. I finished the PhD course in 2014. I majored in medical education. I have been a nursing faculty for 50 years. Now, I worked at Tokyo Medical University in Toji Prefecture in Japan. It is 100 kilometers to the north of Tokyo. It takes about 2 hours by train from Tokyo. Every year, 10,000 babies are born. The total fertility rate is 1.39. It's a little higher than the average in Japan. To the north, by DMU, there is a famous tourist destination called Nikko. It is famous for Toshogun Shrine related Ieyasu Tokugawa, shogun of the Edo period. DMU has a medical school and nursing school. There are 3 hospitals. One is next to my university, and second one is in Nikko, which I mentioned earlier. And third one is in Saitama, just between Tokyo and Tochigi. NICUs are located in the University Hospital and Saitama Medical Center. The NICU of the University Hospital is level 3. It has 36 beds. NICU is 12. The growing care unit has 24 beds. There are 50 nurses. Our hospital has 2 pediatric wards besides NICU. NICU of Saitama Medical Center is level 2. NICU is 6 and GCU has 9 beds. There are 40 nurses. This photo looks a little bit dark because it has dimming system. And then I will start by describing nursing system in Japan. According to the Act in Japan, the roles of nurses are 2 things. One is to assist in medical care to the patient, assistive to medical necessary treatment performed by physicians. Another one is support the daily life of the patient. The patient-nurse ratio of NICU is 3:1, and one of GCU is 6:1. NICU nurses have a lot of time to do direct or indirect care for infants. In Japan, we don't have middle-level providers such as nurse practitioner or respiratory therapist. So nurses don't perform invasive procedure. I'll talk about it later. So neonatologists do directly cure and care for infants and families in NICU. This table shows in NICU that accept small babies under 24 weeks in GA, there are an average of 7 neos and 42 RNs. The average nursing experience is 11 years, and the neonatal nursing experience is 5 or 6 years. It's very short. The average number of certified nurses is 1.4 per NICU. In NICUs that accept smaller babies, there are more certified nurses. The Certified Nurses program was established in 2005. This is 6-month educational program by the Japan Nursing Association. The roles of CNs includes nursing practice at a higher level, education of staff nurses, and serving as consultant for nursing. Over 400 nurses have been awarded the certification of CN in neonatal care. It is the highest neonatal qualification available in Japan. But currently, the CN-NIC educational course is suspended due to various reasons. Now, a new CN-NIC program is prepared in DMU now. It will be 1-year educational program, including e-learning and distance education. Then I will talk about Japanese NICU nurses don't perform injections and blood sampling. I researched with with nurse managers in 2018. This graph shows the answer to which procedure are performed by nurses in NICU. Checking blood glucose is 73%, answer yes, but they hardly do venipuncture, SQ, and PIV placement. Why do NICU nurses now perform procedures? Most nurse managers think that performing invasive procedure is the physician's task. This is information of 10 nurses participants in another my survey. Even a 10 years experienced nurse, she hasn't performed these procedures at all. This shows the workflow of the day for NICU nurse. And the nursing shift is 2 patterns, depend on the hospital regulation. One is a night and day and night shift. Another is a day, evening, midnight shift. The nurses check vital signs, change diapers, and feed every 3 hours. In addition, we give medicine, baby, and educate the mother and father. I think that Japanese NICU nurses are focusing on caring for the baby patient, so we are very interested in developmental care. Reducing light and noise by cloth cover, making utero using a soft bamboo, a cotton swab soaked with breast milk. Then nurse does the sampling with the family. Japanese nurses vary the timing of care. 6 stage of alertness of the neonatal behavioral assessment scale by Dr. Brazeston is popularly used. And nurses decide whether to continue or stop care by reference to the assessment of preterm infant behavior developed by Dr. Aus. NICU nurses in Japan touch the baby very carefully. However, one nurse taught me it is important how to take my hand off baby, not how to touch. The next topic is infection prevention and control. In Tokyo, when nurses care for a baby, they wear PPE, including a long sleeve apron, gloves, medical face mask, face shields, or goggles. When the mother and father comes into NICU, they wear a long sleeve apron, medical face mask, and tie their hair. They have to be without a heart watch, rings, and manicure. Active surveillance culture is done once a week. Change incubator is every 2 weeks. It is important to use the access doors of the incubator properly, and the head side is cleaner than the foot side. Skincare. Bed bath with cotton balls and warm distilled water, and replace ECG dots every day, and change the place to put on pulse oximeter sensor every 2 or 3 hours. Medical tapes selected according to GA and weight. Put guards on the back of the probe. This is bed sheets for the baby of 1 or 2 weeks after birth. We use this one on the left. After that, we use lint cloth. lint cloth on the right side. Thermoregulation. This table is the rule of temperature and humidity of the incubator in Tokyo. After day 3, reducing humidity by 5% while monitoring the body temperature every 2 or 3 days. At this time, raise the temperature of the incubator by 0.3 degrees Celsius. Humidification is stopped when 60% or less. Diaper. So the nurses don't have to move the infant's body, we hold disposable gas into diaper and change only this gas. We sometimes removed or cut these tapes because it is not necessary. This tape is removable, so we don't have to move a baby even in some position. To promote movement of the bowel, we do an enema using a cotton swab and Newton tubes. The last topic is about family. We reviewed 6 papers published in Japan about the parent of a very tiny baby. The emotional experience of mothers in critical periods is a negative feeling. Then after condition of their infant become good, they feel ambivalent. The emotional experience of the father is the same. COVID-19 has put the family situation more serious. It is a busy time that we surveyed 8 NICUs in Tochigi and the neighboring area last summer. Visiting is very restricted. All NICUs have time limits for visiting. For example, 15 minutes, 30 minutes, 1 hour, and so on. The situation has continued still now. Fathers are allowed to visit, but some NICUs do not allow fathers. All NICUs do not allow siblings. This slide shows family care in the NICU. Prenatal care, orientation about NICU for mother during pregnancy, breastfeeding support, KMC and NICU, visiting via Zoom, parent education, for example, bathing, feeding, changing diapers, and medical care such as suctioning, tube feeding, and so on. Transition to home, collaborating with primary care doctor, public health nurse, visiting nurse, social workers. Today I talked about Japanese neonatal nursing. Our strengths are honesty, politeness, industriousness, and kindness, but we have weakness in autonomy and specialization. The nursing strategy for tiny babies has not been clarified enough. it is necessary to identify good practice dialogue all over the world. I'd like to big thank these Nikunas in DMU. Some videos I share you. Wait a minute. Listeners catch from the baby sign and do care very slowly and gently. It's all Japanese NICU do like that. Gently care. That's that's all I have to say. Here my contact details, please. Here, feel free to get in contact. Thank you for your attention.
Thank you very much, Dr. Konishi. Maybe we'll just pass on to Dr. Kusuda now and leave the questions to the end. But if any one of you have any questions to ask in the meantime, please feel free to put it in the chat pane. Over to you, Dr. Kusuda. Thank you. Nadia, there's more to come. Don't leave yet.
Okay, so hello, my name is Satoshi Kusuda, neurologist working in Tokyo, Japan. I'm so privileged and honored to have this opportunity today. So thank you, Julie and Raful. Following the very special lecture on nursing care by Dr. Konishi, I'd like to discuss about practice variation for very preterm infant in different countries. So first, I would like to show the pictures of NICU at Kyoto University. As you know, Japanese NICU is a kind of one floor type, so very big room, one room. And in this room, several incubators are scattered around at a certain distance. And this is a infant of extremely preterm birth, and this is a cross view of the infant. You already heard about the nursing care in Japan from Dr. Konishi. First, I would like to share the outcomes in very preterm infant among INEO countries. INEO means International Network for Evaluating Outcomes of Very Low Birth Rate for Very Preterm Infant. So this is an international collaborative group for the evaluating outcomes and also quality improvement in neonatal care. INEO includes Switzerland, Israel, Sweden, Spain, Canada, UK, Australia, New Zealand, and Japan. First, this slide shows the mortality rate among INEO countries. This is the average mortality rate among all INEO countries. And x-axis shows the number of infants registered. And vertical bar represent 95% of confidence intervals. And here you can see the Japan. Japan showed the lowest mortality among very preterm infant, and then Sweden, and then Australia, New Zealand. However, this slide shows the composite outcome of very low birth weight infant. Composite outcome include death or chronic lung disease, IVH, PVL, or ROP treatment. If we compared composite outcome, Japan was not the best in outcomes. You can also see the increased variation of confidence intervals. So this result means that there is a large variation in mortality and also in morbidity among very preterm infants in INEO countries. This slide shows the variation in practice, morbidity, and mortality according to NRNJ, Neonatal Research Network database of Japan. You can see huge variation in practice, also huge variation in morbidity, and also finally huge variation in mortality. So we can assume that the variation in practice may connect to the variation in morbidity and also finally variation in mortality. So knowing practice variation is very important to improve the outcome of peripretum infant. So today I would like to show the practice variation in these 5 categories: antenatal corticosteroid, delivery mode, resuscitation, respiratory care, and also circulatory care, comparing the practice variation among countries. So first, antenatal corticosteroid use. This slide shows the rate of antenatal corticosteroid use for preterm delivery among different countries: Australia, New Zealand, Canada, Israel, Spain, Sweden, Switzerland, the UK, the USA, and Japan. Australia, New Zealand showed the highest rate of antenatal corticosteroid use at about 90%. However, Japanese mother received less frequently the antenatal corticoid, only about 50%. So this is far below to other countries. This slide shows trends in the rate of antenatal corticosteroid use in the United States. As you know, NIH consensus statement for the use of antenatal corticosteroid was published in 1994. So after that, the rate of antenatal corticosteroid use in the United States increased rapidly and stayed almost 80%. However, the dissemination of antenatal corticosteroid use in Japan has not been rapid like the United States. This slide shows the trends since 2003. The rate has been gradually increasing, however, very slow. The reason why the antenatal corticosteroid rate in Japan is still low is not clear. One possibility is that antenatal corticosteroid use was off-label until 2009. However, even after 2009, no big change. So we should improve this practice further to improve of outcome in peripretum infants in Japan. Next, delivery mode. This slide shows the rate of cesarean delivery rate for peripretum infant in different countries. Switzerland showed the highest cesarean delivery rate of around 80%. Japan was second at around 75%. The UK showed the lowest rate at less than 50%. So again, we can see the practice variation among countries. This slide compares the trends in cesarean delivery rate between Japan and the United States. Japan shows the higher rate of cesarean delivery and still gradually increasing. On the other hand, the USA showed a rapid increase, however, still lower compared to Japan. This is the cesarean delivery rate by gestational week in Japan. At 22 weeks, only 30% of mothers received a cesarean section. However, at 23 weeks, it exceeded 50%, and after that, almost constant at 80%. So therefore, many peripretum infants were born by cesarean section. However, what's the evidence of selecting cesarean delivery for peripretum infants over vaginal delivery? This is a meta-analysis published in 2020. According to this meta-analysis, on cesarean delivery showed significantly less risk for death in infant born before 28 weeks of gestation. However, they could not show any beneficial effect on death or severe brain injury in infants. So therefore, we could not further promote cesarean delivery to mothers having peripretum infants. So next, resuscitation. This data shows the delivery room intubation rate by gestational age in Japan. You can see the relatively high rate of delivery room intubation for resuscitation. Most infants born before 24 weeks of age resuscitated with tracheal intubation rather than CPAP. The reason why the intubation rate of 22 weeks was less than 23 weeks was that some of 22 weeks were not resuscitated aggressively due to the poor general condition at birth. Otherwise, most peripretum infants were intubated in the delivery room. This data compares the delivery room intubation rate between Japan and USA. You can see the gradual decrease in the intubation rate in the United States. However, in Japan, it was almost constant. This video shows the resuscitation of peripretum infants in Japan. So once baby is delivered, you have to wipe out the amniotic fluid to prevent evaporation, and also wrap with plastic film to prevent hypothermia. And then start positive pressure ventilation with a bag and mask. You have to use positive pressure until heart rate of infant exceeded 100 beats per minute. If not, you have to continue the positive pressure ventilation. And if you get enough oxygenation and heartbeat increased, then you can go for intubation. So now ready for intubation. Please do not try to intubate more than 20 seconds. Once you succeeded intubation, you have to ensure the position of tube. It's inserted actually intratracheally or not. For that purpose, we usually use a capnometer. So once you secured the position of tracheal tube, you can fix the tube on lips using elastic tape. So I think this is enough to see the video. So let's move to the next category. But as you see in this video, we prefer to use intubation for resuscitation. Actually, we prioritize the stability of infant rather than avoiding the invasive intubation for resuscitation. So next, respiratory care. This figure compares the respiratory care practice for preterm infant by gestational age among INEO countries. So this is Japan. So Japan preferred to select mechanical ventilation over ensure, LISA, or CPAP for infant born before 27 weeks of gestation. You can compare to other countries. Japan actually selecting intubation and mechanical ventilation for respiratory care. So people are asking, how does the choice of respiratory care can affect the incidence of BPD? This figure compares the trends in BPD incidence among INEO countries, actually published by T. Lui. INEO countries showed different patterns in the trends. Australia, Japan, Sweden, the UK showed the increase in the incidence of BPD. However, Canada, Finland showed decrease in incidence. So, and also other countries showed constant. So therefore, we should understand only the strategy for respiratory care could not prevent BPD among very preterm infants. Actually, the incidence of BPD highly depends on gestational age. Therefore, once lower gestational age infants survive, eventually it would lead to an increased incidence of BPD. Finally, I'd like to discuss circulatory care. Japan prefers in circulatory care for peripreterm infant. Japan prefers to use functional echocardiography for circulatory care in peripreterm infant. That's similar to these groups: Australia, Canada, USA, UK, and Europe. So our approach is not much different from these groups. This figure summarized circulatory management using functional echocardiography in Japan. Today, we cannot go through over details of practices, so please refer to this publication. The most prominent benefit of circulatory care based on functional echocardiography is stable hemodynamic condition of peripretum infant after birth, actually, which can lead to prevention of intraventricular hemorrhage. This slide shows the trend in the incidence of IVH in Japan, showing a significant decrease in its incidence. So we feel functional echocardiography is essential for circulatory management of peripretum infant. Not only the incidence of IVH, we can also see the decrease in severity of IVH. This is grade 1, grade 2, grade 3, grade 4. You can see the decreased incidence of severe type of IVH. Furthermore, if we compare the incidence of IVH with that in the United States, Japan always showed a lower incidence of IVH. So we are very comfortable to use functional echocardiography for circulatory management. So in summary, mortality rate of peripretum infants is low in Japan. However, composite outcome of them is not low. So there are several practice variations among countries. For further improvement of outcome among peripretum infants, knowing this variation in practice is very important. Therefore, international standardization of practice needed in future. Finally, I would like to introduce our manual published 2019. It's NIH manual for infant born before 28th gestation of weeks. I believe sharing this kind of information would be first step toward standardization. Actually, you can download this manual from our website, or you can use this QR code. Actually, I will post this QR code on the chat panel later. So thank you for your attention.
Fantastic talk. Thank you very much, Dr. Kusuda. Before we go on to questions, there's a request to watch the procedure. Everyone's fascinated by the enemas. So Dr. Konishi is going to show us how the nurses perform the enemas in the little babies. Over to you, Dr. Konishi, and then we'll go on to questions.
I shared two videos of enema using tube and swab.
So maybe you could tell us about what size tubes you're using, Dr. Konishi? I'll talk through the procedure.
8 or 10 French tube. How about Dr. Kusuda or Japanese nurse?
And you are putting what solution are you putting into the baby?
Or 12 or 14 French.
You're putting water in.
Water or saline or glycerin enema. Glycerin enema usually
Right.
use.
Okay, and how often do you do that for a baby?
Sorry.
How many times do you do that?
You mean tube or glycerin?
The tube.
Depend on abdominal distension or maybe 1 or 2 a day, I think.
Okay, and then you've got a video of the glycerin enema as well, or the cotton bud, sorry. Yeah.
I don't have glycerin enemas video, so
Okay. Do you have any more videos?
I have never using a swab.
Thank you. Yeah. Okay.
Please wait a minute.
Mm-hmm.
Oh, sorry. Little bit. Okay, I find it.
Okay. Maybe you could talk us through that. So what is the smallest baby that you would do this on?
There are various cases. Maybe.
Okay, that's pretty vigorous. Yeah. Okay. All right, Dr. Krishnamurti, you asked a question about the enemas. Is there anything else you want to know from Dr. Konishi?
Yes, thank you. Actually, you asked the same question. I was more
It's quite vigorous, isn't it?
Yeah, it's quite vigorous. So for a tiny baby in the first week of life, can we do such procedure? Is it safe to do? And we often see babies who get distended without passing meconium in the first week. And they often have some feed intolerance and all. So sometimes we use a small quarter of glycerin to make them evacuate, but we don't do the enemas. So in your experience, do you think it's a safe procedure for a tiny baby, say less than a kilo?
Dr. Konishi or Dr. Satoshi?
Yes, we can do these procedures for all preterm infant. Of course, for tiny infant, we have to do gently, but we always use enema. And also for tiny infant, we increase the frequency, maybe 3 times a day, because they cannot pass through the meconium because their ability to pull out the meconium is very poor. So they need help to actually pass the meconium. So we do routinely. Actually, nurse can do routinely. So they can evaluate how the abdomen is distended, how the amount of meconium passage, and they can decide the frequency of meconium glycerin enema.
Okay, we've got an observation from Miss Selling White, our
Julie, sorry.
nursing boss. Yeah. Oh, sorry. Yeah.
Oh,
Yeah.
can I comment additionally? Yeah.
Of course, anytime on enemas.
yeah.
Yes.
So actually,
Fascinating.
yeah, as Dr. Kusuda explained, we often do the glycerin enema, and we performed a national survey about the management of 22 or 23 weeks gestation of extremely preterm infant, and more than 80% of the NICU performed the glycerin enema routinely, and the starting initiation time is half of the unit using the glycerin enema from day 0 or day 1. And the additional 1/3 of the NICUs started days 2 or day 3. So from the very beginning of the afterbirth, and for the extremely preterm infant, like 22, 23 weeks, most of the NICU performing the glycine enema. But as Dr. Kusuda explained, probably you should be very cautious because it's you have to do very gently. So of course it's a little bit invasive procedure. So when you start using, please be very cautious. That's all.
Wow, the video was quite vigorous.
Oh,
okay.
I think that the second video, cotton enema, is a little for the a little more mature babies. And the first video, initial video is that is not glycine enema, but I think procedure is very similar.
Yes.
To the first procedure, and that's do that procedure very gently. So that is a point, important point.
Okay. I think that's something that there's barrier, psychological barrier that we who are not used to animals need to overcome, right? Yeah. Wow, thank you, Dr. Isayama. Okay, we've got a comment from Sally Wise, our nursing co-director, and she is very fascinated by the number of babies that the Japanese nurses care for. Sally, do you want to unmask yourself? Oh, was she gone?
Sorry, it takes me a while to unmute. Hi, everybody. I really appreciate the talk tonight. And I also said in my comment, I had the opportunity to visit with the ANZNN group back to Japan about 5 years ago. And we also were very fascinated by the enemas, but also the care and the dedication of the nursing staff to care for these small babies. And the fact that your nursing ratios are far, far worse than I think probably Australia, London, or the UK and the USA. But your nursing staff are so dedicated in their care. So well done. And I really appreciate the talk tonight.
Thank you, Sally. All right, so the next one is for Dr. Neo from Malaysia. Her question is, what criteria do you use for extubating the extremely preterm babies, and do you keep them ventilated longer than the other INEO countries? Who wants to take that? That was Dr. Kusuda, right?
Yeah, right. Actually, usually we keep on ventilator until the 20 weeks of corrected age. After that, we try to extubate.
Sorry, 28
weeks of corrected age. So until then, we usually try to keep on mechanical ventilator. After that, we can try the extubation. And after that, always we use CPAP or high flow nasal cannula. So maybe longer than another countries.
How do you keep the babies settled on the ventilator? Do you use sedation?
Acute phase, yes. Some maybe 70 to 80% of NICU using sedation, like fentanyl, during acute phase. But maybe after 1 week, we do not use.
Okay, right. Wow. Okay. Anyone in the comments on that, Dr. Neil? You're good. Okay, so from our no, okay, go.
Yeah. Thank you, Prof. Kusuda. A wonderful lecture. Yeah, we've learned a lot. Thank you. I was just wondering because I think you intubate majority of your small babies in NICU. So I was just wondering how long you keep them ventilated for. Yeah.
So 28 weeks. All right.
28 weeks. Yes.
Corrected. Yeah. Hi, Neil. Hi, Neil. Thank you for your question.
Yeah, thank you.
Thanks, Dr. Neil. All right. So again, the enema again from Esther, our nurse educator, is the enema nurse initiated or prescribed. Maybe Dr. Konishi wants to take this one. Oh, she has typed down no, the neonatologist decide. Esther, do you want to comment on that?
No, thank you. I just wanted to know what is the procedure. because I heard that certain Japanese hospitals, the nurses are initiating the need for enema or not, and this depending on the baby's abdominal distension and condition.
Okay.
Actually, we do not do any order to start enema. As you said, nurse can evaluate and nurse can decide when start enema. But sometimes we just say do not start enema if baby's condition is not suitable for that. So usually we do not do any order. Nurse can decide, but sometimes we just not order not to do.
Oh,
Thank
so
you.
you order in the negative. All right. Okay.
Yes.
So it's more a discussion.
A discussion, a negotiation.
Yes.
Lovely. All right, this is a big one. So from Dr. Nadia Badawi, I think you got to take this one, Dr. Kusuda. Maybe Nadia wants to unmask herself. The rate of cerebral palsy, since your IVH rates are so low.
If I have a time, I would like to show the incidence of cerebral palsy among very preterm infant. Actually, it was decreasing, probably due to the decreased incidence of severe IVH. So actually, it's almost parallel to the incidence of severe IVH. So you are right.
Nadia?
No, just asking about the rate, because I suppose Australia has such a low rate of cerebral palsy now and decreasing severity. That would be very interesting to look at them. Do you have a national register? I'm sorry, I can't remember. I should know.
Yes, we have. So I cannot remember the exact percent, but it's between 3 and 4% of all very preterm infant.
Yeah, and the severity, is it dropping as well?
We do not have a data about severity. Just it's cerebral palsy, so it's GCMS more than 3 or more than 3.
Right.
Yes.
Oh, well, it would be good to maybe discuss it later and compare.
Yeah.
Thank you.
Okay.
Thank you. So we got the last couple of questions now. We are running out of time. We might skip to Dr. Alifa's question from Yogyakarta, since we're on the enema run, and then do the ventilator questions after that. So Dr. Alifa asks, is there any relation between enema and NEC, which is probably our most burning questions for all of us not used to the enema?
So basically, enema can prevent NEC, because if baby cannot pass through the meconium, it's not good for very preterm infant. So in order to prevent NEC, we think enema is very helpful for tiny infant. So however, acute phase of NEC, we do not do enema. So actually, it's a kind of prevention of NEC.
Okay, so now we'll go on to the final two questions. So from there's a big one here, but we'll go on to June's question from Singapore. It's about, this is a short one, I guess, prevention of ventilator-associated pneumonia. Is that a concern since your babies are ventilated for quite some time?
Yeah, of course, if we prolonged the mechanical ventilation, we may have a higher incidence of ventilation-associated pneumonia. But I believe that that incidence of that is not high in Japan. Actually, overall sepsis rate in Japanese NICU is not also high. So I don't think the duration of mechanical ventilation directly connect to the increased incidence of pneumonia.
June, any comments? No? Okay, and the last one, I'm sorry, I don't know who you are, Kusrsei. a ventilation mode for extreme preterms. Now, this is a big one, and I know Dr. Kusuda has saved me many times on WhatsApp about looking after little preterm babies. So the ventilation mode, I think, is very flexible. So maybe Dr. Kusuda would give another talk on this. Maybe you want to have a short answer first?
Yeah, short answer is we prefer synchronized IMV rather than IMV. Synchronized. So SIMV actually.
But you have a little recipe. So when they go on to a different age, you go on to high frequency. Is that right? You've got a lovely little diagram.
Yeah. Almost 40% of infants received high frequency. Yes.
So we might schedule another talk about the evolution of ventilatory needs for the tiny babies. Amazing. Yeah. So you do learn a lot.
Julie, can I share the incidence of cerebral palsy among very preterm infants?
Yes.
So, sorry, this is Japanese, but this is the incidence of cerebral palsy diagnosed at 3 years of age. So it's between 2 and 3% at recent years. So actually decreasing.
Okay, amazing. Okay, that's great. All right, guys. We are out of time. So thank you everyone for joining. Thank you, Dr. Konishi, Dr. Kusuda, for this amazing lecture. Everyone, as usual, is amazingly fascinated by the enemas. I think we will have to have a separate Zoom session on enemas alone. So if you like, we will be posting the talk, the recording of the talk onto our WhatsApp groups, Telegram and WeChat groups, as well as onto our UNSW website. If there are further questions, please feel free to reach out to Dr. Kusuda, Dr. Konishi by email, or get in touch with us if you don't have their contact details.
Actually, I try to put on QR code of our manual on chat panel, but I couldn't. So
you failed.
I failed. So I just posted the link, so you can click that link.
Yeah, we're having a very bad technology day. All right. Well, hopefully we can see you in Japan soon when the borders open.
Yes, the borders open. I believe.
All right. Thank you so much. Thank you.
Bye-bye.
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 Bye.